Good morning, ladies and gentlemen. My name is Sabir Gatti, and I have the pleasure of talking on aortic assessment in athletes. Individuals that participate in regular intensive exercise develop modest enlargement in their ventricular dimensions, which very occasionally overlap with cardiomyopathy. Whereas the upper limits of ventricular dimensions are well established, our knowledge or understanding of aortic remodeling in athletes is limited to a single meta-analysis and a few center studies. But there is a possibility that in some athletes, aortic enlargement may be a manifestation of an aortopathy, which would potentially put them at risk of aortic dissection or rupture. So what do we know about aortic root dimensions in athletes? There are three main studies to be aware of at present. The first was by the Italian group, who looked at just over 2,300 athletes aged 9 to 59 years. And they identified, based on their 99th percentile, that 17 athletes from their total cohort had aortic dilatation defined as more than 40 millimeters in men and more than 34 millimeters in women. And 15 of the 17 athletes went on to develop progressive aortic root dilatation over a follow-up of 8 plus minus 5 years. And they concluded from this study that in this small cohort, this is likely to represent a pathological process rather than physiological adaptation to exercise. The second is this meta-analysis by the Thompson Group from America, where they analyzed just over 5,500 athletes from 23 studies, aged between 15 and 40, and compared them with 700 controls from 13 studies. And what they found was that athletes had a larger aortic root dimension compared with controls by a difference of 3.2 millimeters, and that male athletes had a slightly larger aortic root than females. And they concluded from their study that the effects of exercise training on aortic root dimensions was regarded as small, and that marked enlargement was suggestive of a pathological process. The third is a more recent study by Engel, who looked at 526 professional basketball players. The majority were male and black, and notable for their height. And what they found was that aortic root dimensions, despite the immense body size, exceeded 40 millimeters in a small minority of athletes. That was 4.6%. And when dilatation was observed, it was of a small magnitude. And now, unlike LV dimensions, which retain their direct relationship with height across the measurement spectrum, aortic root diameters reached a plateau at a body height of 212 centimeters. So from this aspect of their study, they concluded that mild aortic root dilatation in athletes is probably physiological, but those athletes at the extreme ends of the height spectrum should not be expected to demonstrate a proportionally marked aortic dilatation. So what do we know about the guidelines for sports participation in these individuals? The former 36 Bethesda guidelines suggested that athletes with an aortic root dimension of more than 40 millimeters should only participate in low-intensity competitive sport. The ACC and AHA recommendations exercise caution with this respect and suggest that athletes with mild aortic root enlargement, or those individuals, males with an aortic root of 40 to 41 millimeters, or females with an aortic root of 36 to 38 millimeters, should undergo 6 to 12 monthly evaluation for assessment of progressive aortic root enlargement. And if the Z-score increases beyond 2.5, then this is suggestive of a pathological process. The European Society of Cardiology suggests that if a diagnosis of Marfan's is uncertain due to incomplete phenotypic expression and or genetic testing is unavailable or negative, then sports participation can be continued with periodic clinical and diagnostic evaluation. So although these recommendations are exceptionally great guide for the physician involved in the care of the cardiac care of the patient, they are informed by a small number of studies. So at St. George's and via the CHRIST screening program, we had the opportunity of assessing athletes from the English Institute of Sport and several other sporting organizations. We assessed just over 3,700 athletes aged between 14 and 35, competing at regional and national level. All individuals completed a health questionnaire, physical examination, 12-lead ECG, and echocardiography. We compared our athletes to just over 800 controls recruited from the CRY screening program, and we also had the opportunity of comparing our athletes with 93 Marfan patients who were gene positive for the fibrillin 1 mutation. We excluded athletes with bicuspid aortic valves, those with a blood pressure more than 140/90, and those undergoing surveillance for an ASD. We measured the aortic roots at the sinus of Valsalva in end diastole, leading edge to leading edge, and the measurements were averaged over 3 consecutive cycles. We also took a cutoff of the 99th percentile to define aortic root enlargement. So these are the results. This table shows the demographics of the 3 cohorts. The male athletes and controls had a similar age and body surface area, whereas the Marfan patients were older and had a larger body surface area. The controls had a slightly higher blood pressure compared to athletes and Marfans, but still within the normal range. 2/3 were male in both the athletic cohorts and controls, whereas there were 50% in the Marfan population, and the majority were Caucasian. Athletes participated in a significant number of hours of training compared to less than 2 hours in the control and the Marfan cohort. This table demonstrates the sports category that the athletes participated in, and although the majority participated in mixed sports such as soccer, we did have a substantial number involved in endurance and static activities. This box plot demonstrates the mean aortic root dimensions in athletes in the red, the controls in the blue, and Marfans in the green. The mean aortic root in the athletes was 28 millimeters plus minus 4.1. In controls, this was 27 plus minus 4.1, giving us a difference of 0.5 millimeters between athletes and controls, and this was statistically significant. The Marfan cohort had a mean aortic root of 39 millimeters plus minus 6, and compared with our athletic cohorts, this difference was 10.7 millimeters. This bar chart demonstrates the distribution of aortic root dimensions in the 3 cohorts, red being the athletes, blue being the controls, and Marfans being in the green. And what I want you to focus on is that a very small minority of athletes had aortic roots of more than 40 millimeters compared to none of the controls, whereas I'd say 2/3 of Marfan patients had aortic roots of more than 40 millimeters as expected. Focusing on the athletes, this bar chart demonstrates the distribution of aortic roots comparing males and females, males being in the blue and females being in the red, and you can clearly see that male athletes had larger aortic roots compared with female athletes. The 99th percentile for male athletes was more than 40 millimeters, and for female athletes in our cohort, which it was 38 millimeters compared to Palicha's group, which was 36 millimeters. Going back to this table on sports category, although there were significant differences between males and females for each of the sporting categories, the type of sport did not actually influence the mean aortic root dimension in the male cohorts, and this was also the case in our female cohorts. So in addition to the type of sport, ethnicity, ethnicity and body surface area and other echo parameters did not have an influence on the mean aortic root dimension. But the hours of training the individual put in and older age did have an influence on the mean aortic root dimension based on the multi-regression analysis. Athletes with aortic root dilatation were followed up for 5 plus minus 2 years and have not demonstrated a progressive enlargement in their aortic roots and have continued to participate in sport. So the take-home messages from this study is that aortic root dilatation has important implications in terms of risk of rupture, particularly those individuals in participating in regular sport. Athletes do exhibit a slightly larger aortic root dimension compared with controls. Very few British athletes had aortic roots of more than 40 millimeters, which is reassuring. And that if you do have athletes who have male athletes with aortic roots of more than 40 millimeters and female athletes with aortic roots of more than 38 millimeters, then we would recommend follow-up with echocardiography annually. And if there is a progressive, with a view to disqualification, if there is a progressive aortic root enlargement. Thank you very much.